suspicious that this is a herpes problem. Also, if there is some iris pathology, so that shining the light through the pupil and looking at the iris, one can see some transillumination defect. This is herpes until proven otherwise. And I will treat that patient with systemic antiviral therapy while continuing to pursue the diagnosis through additional studies. Is the sclera involved? That's very important to determine. You know, the herpes patient will have the red eye, but may not have other evidence of scleral involvement. Other evidence of scleral involvement should raise the specter of a systemic disease, a vasculitic systemic disease, like granulomatosis with polyangiitis, or lupus, or polyarteritis, or rheumatoid disease. Is there vessel inflammation in the retina? Is there a vasculitis present? That's going to be disclosed by the features on the fluorescein angiogram, which we're very generous in doing at Mercy, to see if there's a vasculopathy, and if there is it an artery involvement, or is it a vein involvement, or both? And that then is going to bring us to the question of whether or not there is a systemic vasculitis as well. Non-vasculitic systemic disease is pretty common, at least here, with sarcoid being the primary problem. Or is it strictly ocular matter? If it's strictly ocular, then it's going to be infectious, or it's going to be paraspleenitis. We'll also characterize the problem in terms of its onset, duration, and course. Was it sudden onset or slow, insidious onset? Has it been going on for a limited amount of time, or has it been going on for a long time? A long time, in my view, is greater than 3 months. And was it sudden onset and limited duration, or recurrent multiple episodes? Here's a good example of keratic precipitates. These are not big, juicy, fat KPs. These are smaller KPs. So this is a non-granulomatous case of uveitis, in contrast to the big, juicy, fat precipitates on the back of the cornea seen on the left slide in this panel. These button fat KP are typical of sarcoid or other granulomatous diseases. And of course, if one finds a frank iris nodule, now you know that you're dealing with a systemic granulomatous problem. The differential of granulomatous uveitis is pretty limited. Sarcoid, and more sarcoid, and these other things listed on this slide are the usual suspects. Herpes and syphilis can produce granulomatous uveitis, although they usually produce non-granulomatous uveitis. This is a case of one of my patients who had leprosy as the cause of his granulomatous uveitis. The major uveitis are seen in this table, grouped as infectious, or associated with systemic disease, or not associated with systemic disease. And this is complex, and I'll be returning to this by the by as I go on through the other talks on uveitis. Infectious uveitis is almost always viral, with syphilis being the primary bacterial problem that can cause infectious uveitis. Systemic diseases that can cause uveitis include the B27 associated diseases, JIA, sarcoid, Behçet's disease, and then of course non-systemic disease, Fuchs heterochromic iridocyclitis. Here's a good example of a hypopion in one of my patients who had uveitis secondary to herpes simplex virus, but other diseases can cause a hypopion too. The most famous systemic disease that causes hypopion is Behçet's disease, but it can be seen in other diseases as well. And what you're looking at now is a posterior subcapsular cataract in a patient who had Fuchs heterochromic iridocyclitis. And here, of course, is a granulomatous uveitis with nodules and synechiae. And this patient has herpes simplex with iris heterochromia. If a patient has intermediate uveitis, the things that can cause that are more limited as opposed to anterior posterior uveitis. Syphilis and Lyme disease can do it, but also multiple sclerosis and sarcoid are the notorious systemic diseases that can cause intermediate uveitis, seen here in a representation of the collection of inflammatory cells at the pars plana and in the vitreous cavity as well. If there's no systemic disease that can be identified in a patient with this sort of problem, then it's idiopathic pars planitis. The systemic diseases that can cause the infectious systemic diseases that can cause intermediate uveitis include syphilis and Lyme disease, and of course the non-infectious diseases that are famous for causing intermediate uveitis include multiple sclerosis and sarcoidosis. Here's a good example of intermediate uveitis with posterior involvement with cells in the vitreous and aggregating into clumps as well. And here's phlebitis in a patient with sarcoid. And here's phlebitis in a patient with non-sarcoid disease. So what about the retina? What about the posterior uveitis that could be associated with retinopathy? Well, it could be primary or secondary. It could be because of frank retinal involvement or secondary involvement because of a choroiditis underneath the retina. The descriptions that one wants to use are important. They can guide another doctor who's seeing this patient from another part of your state or another part of the country and speaking the same language that you're speaking and describing the problem. Choroidal spots should be described as well, and a number of things can cause choroidopathy, including both infectious and non-infectious diseases. Here's a good example of a person with choroidopathy and vasculopathy who has an infectious disease, and specifically CMV retinitis. So one wants to be as clear and descriptive as possible in laying out the terms that one wants to use to describe the person with posterior segment involvement. Many of the times we're going to see patients who have no systemic disease, and we'll just try to characterize it as posterior uveitis and try to put it through the descriptions that I've mentioned into one of the categories that you see here. Here's an example of a patient with sarcoid uveitis with phlebitis and also spots in the retina. And this patient has more serpiginous looking uveitis with involvement of the vasculature. Now this person has something else. We're going to add something to this. This person has an involvement of the optic nerve as well as the vasculature. This person turns out to have a chest disease. And what is this? Well, there are spots. One would also see on an angiogram that there's a phlebitis. These spots are deep to the vasculature. It turns out that this patient has birdshot retinochoroidopathy. So you want to use your imagination and be as eloquent as you can be in describing what you're seeing in the anterior chamber, in the intermediate zone, and in the posterior segment as well. Sizing the patient up from the standpoint of the vision is crucial. The intraocular pressure is crucial. How many patients with uveitis also have elevated intraocular pressure? Well, if they do have elevated pressure, that limits, in my experience, the number of potential contenders in the diagnosis, with, of course, herpes simplex virus being notorious for being associated with elevated pressure. And then, of course, there's the matter of trying to grade the inflammation, both in the anterior chamber and in the vitreous. The small working group has tried to help. Recommendations for grading anterior chamber cells. You see their system here. I try to abide by that system. And then, of course, there's also the matter of the vitreous. Now, the anterior chamber can contribute to the so-called flare, the leakage of protein into the anterior chamber, and one wants to try to grade that. I have a cell and flare meter, but they're few and far between through other practices around the country. The group in California at UCLA has done a lot of work on that matter. And then, of course, there's the vitreous, which is the worst of all. I hate it. So does every other uveitis specialist whom I know. Uveitis specialists routinely disagree when they're shown a patient, much less a series of photographs, on grading the vitreous haze. But one needs to try and make an effort at grading the vitreous haze. This slide, for example, shows clear-cut 4+ vitreous haze. The disc is obscured. The disc can be seen here, but not clearly. So that's the point. Try the best that you can to give a grade to the amount of haze in the vitreous in a person with posterior uveitis. Grading the cells in the vitreous is not at all easy. Attempts have been made by my group and by Nussenblatt's group at the National Eye Institute. And so all I can say on that score is that one should give their best effort at describing the number of cells in the vitreous if you can. The workup of a person with uveitis is terribly important. You want to do your best to make sure that you're not dealing with an infectious problem, because using steroids or an immunosuppressive agent in such a case can make matters worse. You want to make a best effort at identifying a systemic disease that could be causing the problem and choose your therapy appropriately and give the patient what you think the prognosis is for their case. Many of the cases that we deal with are going to be long-term. They're going to be on therapy of one form or another for very, very long periods of care, and you don't want that to be corticosteroids, if at all possible. that should be avoided. So we work our patients up carefully, being guided extremely by the History and Review of Systems questionnaire. One should always use a questionnaire that keeps you from overlooking things that one would want to be asking questions about. Signs and symptoms, ocular and medical examination are crucial. You know, the patient's sitting there in your office, and you can easily examine that patient's skin, not just their eyes, but also their skin and their fingernails, looking for clues that could give you a sense of an underlying systemic problem that the patient has. By doing those things, you can then plan on laboratory testing. There are very few things that here at my office at Harvard, at Mercy, very few things that I routinely get on everybody. But a serologic test for syphilis is one of the things that I never ever omit. I always get not just a VDRL, but also an MHTP or an FTABS on every patient with uveitis. Every patient with uveitis gets screened for having occult syphilis. Syphilis can cause uveitis. It does so commonly, and to miss that would be a huge mistake. So we always consider syphilis and sarcoid and TB in our patients, and also keep in the back of our minds the possibility that this might not be uveitis at all. This could be a masquerade. This could be lymphoma masquerading as uveitis. The traditional serologic tests for syphilis are okay, but they're not enough. They should be gotten, but MHATP and FTABS should also be gotten. 30% of patients who in fact have syphilis as the cause of their eye inflammation will be RPR or VDRL negative. So look deeper with the treponemal specific serologies as well. Other things can be done to dig deeper. Getting enzyme immunoassays performed can be done. And the RPR should be followed as well as the MHTP or TPA in response to the therapy for syphilis. Lyme disease, we don't see much. You'd think that in Massachusetts we would see a lot of Lyme disease. I mean, it was named, for goodness sake, for the town in one state south to us, where it was first described by Dr. Stone. But in spite of that, we don't see much Lyme disease. We do test it. The patients are routinely screened for Lyme disease. They are going to have 2 IgM bands on Western blot or 5 IgG bands on Western blot for us to be highly suspicious and to treat them for Lyme disease. What about TB? Well, it's not a common cause of uveitis, but like syphilis, it's out there and it can cause uveitis. My test for TB is quantiferon gold test. It's highly specific, and we don't do much skin testing, but we screen everybody with quantiferon gold. The patients with TB causing the uveitis is probably going to have some findings in the posterior segment, not just anterior uveitis. They're probably going to have a vasculopathy, a granuloma in the choroid, spinous-like disease, in the posterior segment. So all of our patients who we think have serpiginous choroiditis get tested aggressively for TB. I don't screen for Bartonella unless the patient has a neuroretinitis. If they do have retinitis, then they are screened for Bartonella. And we'll also take fluid for doing PCR, polymerase chain reaction analysis for Bartonella. The patients with toxoplasmosis are absolutely going to have a chorioretinal lesion. I've never seen a patient with toxo who did not have a chorioretinitis. What about actually B27? Everybody in my practice gets screened for B27 positivity. They're also going to be looked at one way or another for spinal arthritis, sacroiliitis. ANA is used as a screening tool in every kid with uveitis. They will have positivity in those patients who have JIA, juvenile idiopathic arthritis. Patients with TINU will have beta-2 microglobulin in their urine. And so we look at that in the children with uveitis. ANCA is not a routine test for uveitis. It's not common. I see a lot of it because the patients that I see are often with systemic disease and specifically with a systemic vasculitis. Sarcoid can occur in anyone. It doesn't necessarily cause granulomatous uveitis like you see here, but it can produce that. It can also be non-granulomatous uveitis. And so we look for sarcoid in almost everyone. Very few people have lung involvement or skin involvement, but they may. So if I'm suspicious of sarcoid, I will get an upper body CT scan looking for nodes in the lungs. They're often going to have an elevated angiotensin-converting enzyme and or lysozyme. And so I get that on everyone that I'm suspicious of having sarcoidosis. Liver enzymes may be abnormal, but this is less sensitive than the ACE and lysozyme. Imaging is very important, though, in the patients that you're suspicious that they might have sarcoid. And here you see a chest CT scan showing the node enlargement. And here's the chest X-ray in the same patient. Biopsy is important in those patients that you're suspicious that they may have sarcoidosis, looking for non-caseating granuloma. And blind conjunctival biopsies are not terribly useful. They are positive in 10% of patients with uveitis secondary to sarcoid. The patient who has sarcoid may well have phlebitis. They'll have uveitis, cells in the vitreous, and phlebitis as seen here. And the angiogram will be telling in that it'll show the vasculopathy better than the just plain ophthalmoscopy. A definite diagnosis of sarcoid can be made in a person who has posterior uveitis and a positive biopsy of the conjunctiva or the lung. Presumed sarcoid can be based on the presence of uveitis plus bilateral hyaluroretinopathy in the absence of a biopsy. And a probable sarcoid patient will have the uveitis that's compatible with it and 3 signs and 2 labs on investigation. Possible sarcoid, it's okay to use that. We do it here at Mercy. Patient has the uveitis that's compatible, but they don't have pulmonary findings or an elevated ACE. Chest X-ray, sacroiliitis, sinus films, Wegener's, sarcoid, and B27 associated disease are the usual suspects. CT scanning and MRI scanning can be used to dig deeper, and a B-scan is going to show in the person who has these kinds of things retinal pathology. The fluorescein is indispensable. I've seen a lot of patients over the years who have not had a fluorescein angiogram. They've had a lot of OCT scans, but they've never been angiogrammed. And the angiogram is indispensable in many patients with posterior uveitis. And one's going to find the telltale vasculopathy or disc pathology in 9 out of 10 cases. ICG can be additionally useful. Here you see one of my patients with birdshot with choroidal lesions. Other imaging can also be useful. I don't poo-poo the idea of OCT scanning. Just don't rely on it exclusively in the absence of fluorescein angiography. OCT, fine, do it, but also get the fluorescein, please. The finding of fundus autofluorescence is useful. One wants to look for that in every patient. It's easy. You're not going to have to be injecting dye, and that's going to be positive in patients with choroidopathy, the white dot syndromes in particular. So in summary, in the last minute that I have for this segment of this lecture, one wants to try as best one can through being eloquent in the discussion, describing the uveitis, the presence of the inflammation. Is it likely to be infectious or non-infectious or a masquerade? Is it anterior, intermediate, posterior, or pan-uveitis? And then you're going to put together a collection of laboratory tests that you'd like to do. If there's no suspicion at all for infectious disease, you can move along looking at systemic diseases that can cause uveitis. That's all I have for that talk. My next talk is on anterior uveitis.
Yeah, Dr. Foster, if we can pause here for a moment to see if there are any questions from our audience here. While waiting for anyone who wants to ask Dr. Foster a question, I want to start.
Quan, I can't hear you.
Let's see. Can you hear me now?
A little better. Can you face the, yeah.
Yes.
Now.
So I can start first a question, and it has to do with herpes. So as you astutely pointed out, herpes is often misdiagnosed or missed by many because of most people don't think of that. But then there's also a colleague who would decide that based on just the clinical finding, as you mentioned, like unilateral ocular hypertension, one iota finding, will automatically start the patient on treatment, whether there is or there's not finding of a positive titer or any type of confirmation, be it AC tap or anything. So what are your thoughts on empirically treating an eye as a hepatic uveitis without any laboratory confirmation, without any serologic finding?
So the patient who has herpes simplex virus as the cause of the uveitis is often going to show something more than just the uveitis. Careful testing of corneal sensibility will often show that they have depressed corneal sensibility. They've never had keratopathy. They've never had a dendrite, but the nerves supplying the corneal sensation will be impaired 9 times out of 10. So we're very keen on carefully assessing the corneal sensibility. They may show areas of iris atrophy. That's not so easy to see in the person who's not looking for it, but finding areas of patchy iris atrophy is also common in patients with uveitis secondary to herpes simplex virus. And then, of course, we'll get the serologies. And the serology is, if they've never had herpes, then the herpes diagnosis goes out the window. If the majority of patients in civilized societies have had herpes, even though they don't know it. So if they're antibody negative, then we just move along and pay attention to the other things that can cause uveitis. If they're antibody positive, then we keep that as a possibility.
Yes, I think I agree with that, because I have taken a number of patients off of valproic since I came to the Bay Area here, because of the fact that many colleges put them on them, and then when we do truly testing to various ways, I just could not have any positive results. So I think that's very important to know. Yes, it could be similar to other entity, but in order for us to treat, oftentimes we should have some positivity result before we start to treat that. We have a question from one of our resident urologists. So the question is, if a patient has uveitis for more than 3 months but was never treated, would you describe or classify that patient as a patient with a chronic uveitis?
Yes, I think the Sun Group has come to the agreement that uveitis lasting more than 3 months is classified as chronic.
Yes, I think so. So the answer there would be to Ahmad is that whether with or without treatment, if the disease has lasted for more than 3 months, then we should consider that aspect there for that thing. So that's the form aspect. Can you also comment, Dr. Foster, on the comparison between anterior chamber paracentesis versus vitreous sample when you suspect certain infectious etiology, for example?
Sorry, I'm having difficulty hearing.
So my question is, when you look at between anterior chamber paracentesis versus diagnostic vitrectomy, do you, in general, the diagnostic vitrectomy tend to have maybe a little bit better result in terms of PCR outcome and finding? Do you agree, or do you think that a lot of time you will be able to get away with simply the AC tap?
Well, I don't think it's black and white. I think that AC tap, of course, is completely innocuous, and I would strongly recommend it to anyone who is considering an infectious cause of their patient's intraocular inflammation. And of course, with a short fuse, to move along to a diagnostic vitrectomy if the AC tap is negative.
Great. Any other question from our audience for Dr. Foster? Okay. If not, we will move forward to the next lecture by Dr. Foster on the treatment paradigm. So while Dr. Foster put his talk, one of the things I have learned is the quantiferon testing. I fully agree that is when we should test, but in some hospital, for some reason, there's still the difference between quantiferon and quantiferon Gold Plus. So if you order, just make sure you check that because sometimes I have seen where the testing was positive with the quantiferon Gold Plus, because we were quite suspicious to retest it, versus if you just do the quantiferon only with that. And then there has been a number of publications on the management of ocular tuberculosis through the COTS group, the Collaborative Ocular Tuberculosis Study Group. And that's a details for us a lot of time, how do we treat them using both anti-infectious as well as anti-inflammatory approaches. And
can you help me out? I need to know whether or not you can see my anterior uveitis slide.
I do not. I have not.
So I need
Dr.
help.
Foster, I think you need to go down to the bottom of your screen on your Zoom window, and you should see a green button that says Share Screen underneath everyone's little name tiles.
I'm not finding what you're talking about.
Are you seeing, what are you seeing on your screen right now? Are you seeing your video or?
I'm seeing Quan and me.
Okay.
And
at the bottom of the screen, Dr. Foster, at the bottom along the line that say like chat, poll, question and answer, there's a green box that says share screen.
Got it.
Okay, I think you click on the share screen and then that should work. Yes, great. And now you go to your thing that just hit like the slide presentation mode. Yes, perfect.
All right, so this topic is anterior uveitis. And let me start by sharing a case with you. 18-year-old male referred for sudden onset of redness, blurring, and irritation in the left eye 2 weeks earlier. He was seen in an outside clinic. They did some blood testing on him, found nothing, and put him on topical steroids every 2 hours while awake and cyclopentolate twice a day. He got better. He had had a previous episode 4 years prior to this, and on careful history taking, he confessed to having had occasional low back pain years earlier that he attributed to exercise. His vision was very good and his pressure was normal, but at the time that I saw him, he had 1+ injection with 3+ cells and flare in the anterior chamber with a plasmoid aqueous. There was new adhesions between iris and lens, and his lens was clear, but it was also clear that he had some cells in his anterior vitreous. So here he is. You can see that there are areas in the pupil that are irregular. It's because of sticking to the lens. You can also see the ciliary flush that he has here. And the arrows are pointing to the posterior synechiae. So what would you be thinking about in this person who has mostly anterior uveitis and it has been impressive? Well, it could be idiopathic, it could be JIA, or it could be B27 associated uveitis. It could also be something more ominous like Behçet's disease or an infectious uveitis. At the initial visit, what would you do? He's come to you from another doctor, so you're the expert now. What do you want to do for this patient? Well, you're going to investigate him a little more deeply, aren't you? You're also going to treat him more aggressively. I treated him with intravenous solumedrol, 1 gram, and I gave him my so-called dynamite cocktail, which is a mixture of atropine and epinephrine and cocaine. Some of the synechiae were lysed during that visit. I put him on industrial strength steroids, prednisone by mouth, difluprednate every 2 hours while awake, and atropine. And I got a rheumatologist consult. I did some supplemental blood work myself and saw him 3 days later. He was better, but he still had some cells in the anterior chamber and some posterior synechiae that hadn't been broken. 2 weeks later, all the synechiae were resolved. Inflammation was reduced, and he's B27 positive on the lab studies that were done. The rheumatologist found nothing. So what did the rheumatologist do? Well, the rheumatologist didn't do much because he thought that the patient was normal and healthy, but he did examine him. He looked at his feet and his peripheral joints, and he asked him to bend at the waist. And the patient was perfectly flexible and had no evidence of ankylosing spondylitis. But I did think that he had a B27 associated anterior uveitis in this left eye. Here's what he looks like when the uveitis has resolved. Good light reflex coming from the cornea, chambers deep and quiet, pupil is normal, no synechiae. So why aggressively work him up? And why treating him? My treatment of him was aggressive, systemic and topical steroids. It's because without breaking this episode of acute uveitis, he could end up with some impaired vision. We wanted him evaluated by the rheumatologist because if he turned out to have ankylosing spondylitis that was early on, he could have decreased quality of life for the rest of his life. So if this man had been a child, the impact of the disease could be far greater than just for the patient himself. Other members of his family are going to be mightily impacted by this child's anterior uveitis. Gritz and Associates in California estimated that 70% of all uveitis that they saw were just anterior uveitis. Why is proper assessment of that problem important? Because it has a direct effect on successfully treating the problem and preventing the patient from losing eyesight. You might even find a systemic disease in the course of evaluating this patient who has anterior uveitis. You've seen this before. That's the Sun Working Group grading system for anterior chamber cells and for anterior chamber flare. Here you see synechiae already starting to form. And the assessment of the anterior chamber is done with a 1 by 1 millimeter square beam of light shot across the anterior chamber obliquely. 1 by 1 millimeter square. I like to tilt the tower on my microscope, on my slit lamp. For doing this, I think that brings out things that ordinarily could be missed if they were subtle. The degree of flare and the amount of cells in the chamber. What about precipitates on the back of the cornea? Well, they might be small or they might be fat and juicy. Mutton fat KP are seen here. Non-granulomatous KP are seen here. Star-shaped KP are seen here. The stellate-shaped KP are more typical of patients with pseudochromic keratocyclitis. What do you want to do? Well, you want to step in boldly. The house is on fire, so you'd like to call the fire department to put the fire out before there's damage. Snuff it out. Symptoms get better, the signs get better, and you're probably going to prevent secondary complications such as cataract and glaucoma. These things with aggressive initial therapy are going to be prevented. You don't want the patient on chronic steroid, but aggressive initial therapy with steroid is going to prevent that. You're not going to have the patient on chronic steroids. Get the fire put out and then move along. The risk factors for ongoing inflammation in patients with JIA include the presence of posterior synechiae. That's a very important finding in the kid with anterior uveitis. Posterior synechiae is a bad sign. It's going to prompt you to see that patient more often than you would otherwise be seeing the patient. Low pressure, cataract are other indicators that this is going to be a bad case. What about cataract? Not such a big problem, right? Well, it turns out that it can be a very big problem. It certainly is going to make the cataract surgery more complicated, and it may preclude the use of laser in your assisting making your capsular rhexis. I would guess that nobody in the room is going to be excited about tackling this uveitic cataract. We love it. We love these cases. Drops are not going to make the pupil bigger, but you know that you're faced with the need for pupil enlargement at the time of cataract surgery. You might even still be able to do a femto laser assisted capsular rhexis in a person with this kind of cataract once you get the pupil enlarged with whatever it takes to make it larger, iris hooks, for example. Now, what are the risk factors for long-term low pressure?
How'd it go?
The longer the uveitis, the higher is the likelihood that this patient's going to end up with hypotony. If it's bilateral, if the vision's poor, higher likelihood of long-term low pressure. Posterior synechiae, another indicator that this is a bad case and you're going to have long-term hypotony. What about the opposite problem? Glaucoma. How does that factor into your sizing the patient up and figuring out his or her risks? Well, high pressure is more likely if there are posterior synechiae. Posterior synechiae much more likely to end up with high pressure, long-term, that has to be dealt with drops or surgery to control the pressure. Patients with Voigt-Koyanagi disease are at special risk for developing long-term high pressure. Aggressive immediate therapy is crucial for these patients who are starting to form synechiae, you're gonna have one shot at it. So be aggressive with the steroids and with the dynamite cocktail, potent topical steroid, potent intravenous steroids. Be very aggressive with the therapy on these patients the first time you see them. You're only going to have one shot at this, so be very aggressive the first time you see them. 16-year-old female, red eye, OD uveitis, one-day history of blurry vision, 2100. But look, you see, this is a problem. This is a real problem. The pressure is 37. The patient's got iris Bombay and already has some corneal edema because of the elevated pressure. It's a big problem. You can be the difference between long-term trouble or a short-term resolution of this, even if it required a laser iridotomy, which it did in this case. Aggressive medical management followed by laser iridotomy 1 day later. And here you see the post-treatment anterior chamber depth. Otherwise, it's going to get worse and worse with chronic synechiae and intransient cells in the anterior chamber and the need for glaucoma surgery. This patient, for example, has a pressure of 52 with 3+ cells in the anterior chamber and iris Bombay. Things aren't going anywhere. That person is going to require glaucoma surgery. And she got an LPI and aggressive steroids and oral steroids, and 1 week later is doing better. So use the appropriate medication in each case. Severe inflammation warrants very aggressive therapy. I've not seen this, by the way, in any of my patients, adults or otherwise. It's a possibility, so you need to be aware of it. But a parasympathetic side effect can occur in patients who are having aggressive cycloplegia. Now, the B27 gene is widespread all throughout Europe, South America, and the United States. The percent of anterior uveitis secondary to patients with that problem. Now, by the way, the gene doesn't cause the problem. It requires a two-hit problem. Being born with the gene, inheriting the gene, but also something triggers it. It can be a bacterial germ or a virus, but something has to trigger it. And sometimes you can figure out what the trigger was. Males are more commonly affected by this than females. This is a study that was done looking at the anterior chamber cells and B27 associated uveitis. And they were mostly neutrophils. Associated findings in patients with B27 uveitis. Well, they are likely to have a secondary disease. Ankylosing spondylitis is the most common, but they're also likely to develop complications like posterior synechiae and end up with bilateral disease by the eye. There can be a delayed acceleration in the severity of inflammation in patients with B27 associated uveitis, and I've personally seen that. Not so bad the first, second, or third, or fourth time that they get an episode, but as they get further into their history, it can become worse and worse, and the price you have to pay with aggressiveness of therapy will get worse and worse too. Treatment for a mild flare-up, topical therapy, observation, but if they worsen, get aggressive, systemic steroids, intravenous medication, even periocular injections, and a strong cycloplegic. The Dublin uveitis trial resulted in the development of a proposed guide for referral of patients who are B27 positive. Spondyloarthropathy was seen in the Dublin patients in 41.5% of the patients who had B27 associated acute anterior uveitis. They had had their backache for almost 10 years. So these patients can have underlying spondyloarthropathy that they have minimized in terms of its importance. They haven't been referred to a rheumatologist, but it's appropriate to get it looked at. Referral to a rheumatologist, I think, is important. Beware of the anterior uveitis consult. Often presents with other forms of inflammation, like scleritis. Patient with uveitis comes in, they've got a red eye. Well, you expect them to have a red eye, right? But that red eye might be secondary to scleritis. Look deeper. Dilate the pupil, do whatever it takes to move the pupil, and look at the optic nerve and look at the retinal vasculature. I think if you find vitreous cells or disc edema, you know that you're in for trouble. This patient is in for trouble. This patient's in for a long haul of it. So be careful. Look long and deep. Dilate, do whatever it takes to make the pupil big, and look deeper. Complications are seen more frequently in the B27 patient than in B27 negative patients. One of my former fellows, Billy Power, who is in Ireland, did his work when he was with me in Boston, and he found that patients who are B27 positive were in for more trouble than those who are B27 negative. All right, the B27 patient who has anterior uveitis, and what is this? Do you think that this patient has scleritis? Well, rub on the eye. I mean, through the closed lid, rub the eyeball. If they're tender to the touch, that's scleritis. What about other things like retinal vasculitis or disc edema? Look for that. If they have those things, this is going to be a bad case. You're going to be living with this patient for many, many years. I personally vastly prefer wide field angiography to conventional angiogram. And as far as wide field angiography is concerned, I've got a strong preference for the Heidelberg system as opposed to the non-Heidelberg system. This is what we found in this patient. Before getting the wide field system, this is all we could see. With a wide field camera, we find peripheral retinal vasculitis. It's not rare in patients who you think just have anterior uveitis. And it's going to lead to other things like macular edema. This JI patient with anterior uveitis was treated with an escalating cascade of medications. First, a nonsteroidal, then Imuran or azathioprine, then cyclosporin was added to the Imuran, then intravenous infliximab, then adalimumab, then tocilizumab. So you can see that anterior uveitis may or may not be simple. It may require polypharmacologic approach to bringing the problem into control, as it did in this patient. I kept this patient quiet for 2 years. She went on to go into become an OBGYN doctor in New York. She's been off medicine now for several years, still quiet. There are other things that can be done. Things in the pipeline include using electricity to drive drug into the anterior chamber. Aldehyde trap is another therapy that's in trials now. The eye gate device is seen here. It's not painful. They may feel a little buzz or tingle, but this can drive a lot of steroid into the eye extremely quickly. And the aldehyde trap by Aldera can be used very effectively to put the stubborn uveitis problem into remission. Finally, there's surgery. I've done a lot of surgery on patients with uveitis, and almost always successful, almost always helpful. Here you see a patient with an iris pupil expander. It's a small gauge vitrectomy that's being done, and the outcomes are typically very, very good. Aggressive anti-inflammatory therapy beforehand, and then a vitrectomy. Now, what about patients with choroiditis? I treat them the same way as anterior uveitis patients too. I get them quiet. If I need to use systemic drugs, I'll do it. In this case, I used naproxen first, but then moved along to methotrexate, low dose, 15 milligrams once a week. And currently the patient's in steroid-free remission for 1.5 years, and had some low back pain, but did not have ankylosing spondylitis. So excellent outcomes can be achieved with appropriate aggressive initial management. Delay in treatment may lead to irreversible complications and or chronicity. Recurrent or chronic disease requires long-term management and may require recipe building, polypharmacologic therapy, may even require immunosuppressive chemotherapy and management of potential complications from such therapy long-term. But I would implore you to not trivialize a patient that comes in with anterior uveitis. They may have anterior uveitis plus some posterior segment problems too, and you may have to get extremely aggressive with recipe building and even surgical care in their long-term management. I thank you for your attention. I'm happy to take questions.
Yes, thank you, Dr. Foster, for that. I certainly appreciate very much in here, and the audience too. We have 2 questions and then have some comments as well. So one of the first question has to do with the way that we assess the flare and cell. So one of our colleagues asked, when you discuss about looking at the flare and you talk about the tilting the device, do you mean that you want to tilt the illumination tilting large? Do you have to tilt it actually, or you just turn it aside to get the beam to be able to see the cell and the flare? Or do you actually need to bend it?
I'm so sorry, I ran off the railroad tracks during that. Try again to answer the question.
Yes, the question has to do with on a tilt. When you talk about on the tilt, I address it on the slit lamp so that we can look at flare and cell and so on. Do you mean that we just turn the slit lamp to the side, or do we actually have to actually tilt the actual device into.
Oh, okay. So tilting the tower. Why do I do that? I really don't know why I do that. I don't know where I learned that. I've tried to look it up, read about it, but tilting the tower has an amazing optical effect on my ability, at least, to see cells and to see flare in greater detail. I would advise all of you to give it a try, see what you think in your hands. Does it help you see cells in the anterior chamber better or not? I think you'll find that it does help you to see cells better. I tilt the tower, I don't know, probably 15 to 25 degrees tilting.
Great.
Who asked that question, by the way?
This is from Dr. Michael Mack, rather, one of our young ophthalmologists. He's an audience.
Well,
right
bravo
now.
to that doctor. Almost no one thinks to ask that question. And I'm going to congratulate him because I think it's clever of him to think of it.
Great, thank you. The second question is that, can you repeat again the dynamite cocktail that you used to break the synechiae?
Yeah, my dynamite cocktail is comprised of 3 components. One is epinephrine, 1 to 1,000 epinephrine, equal amounts, by the way. I put 10 drops of one thing in, and then 10 drops of another, and then finally 10 drops of another. So 1 to 1,000 epinephrine, 4% cocaine, and
Atropine.
pardon?
Atropine in it or no?
And 1% atropine.
Yes. So that you mix in that, and when we would you then take a cotton ball, you soak in there, and then you leave it in the fornix of the patient, and then you.
So I use cotton that I'm tearing off of the end of a Q-tip and roll it up to make it a bit of a torpedo shape. Soak it in that, and then stick it down in the inferior fornix of the patient, and ask them to remain there with their eyes closed for the next 20 minutes.
Yes, and that does work. So I have tried that also too. The other point I want to mention is that we have heard Dr. Foster talking about that even for patients who come in with anterior uveitis, please make sure you look at the posterior segment, and that is absolutely very, very true here. So a number of years back, Dr. Foster group in Boston have published that the incidence of posterior segment disease, for example, retinal vasculitis and so on, was about 20 or so percent, 25% in patients with chronic anterior uveitis. And that was before the era of the wide angle fundus angiography and photography. So our team now at Stanford, we just recently looked at our own population here, and that number is actually up now, in almost in the 40%, and especially if you have had anterior uveitis for more than 6 months or so. So many times that has been missed by many colleagues because they just simply not looking and not performing the appropriate test, and it's very sad to see that. So if you're managing, just please take the time to look at it, especially if the patient has a chronic anterior segment disease, because you will be very surprised to see why the vision not get to that perfect level, because either the optic nerve is inflamed or there's vasculitis occurring in there. And so that's something that we have seen so often of the problem.
Excellent point, Quan.
So that is great. Any other question going on right now? If not, I think everyone is very, very tired too. So we started day very early. So thank you, Dr. Foster, very much again. And this will basically end our afternoon session right now. It's 2 p.m. right now in Palo Alto, California. And so it's already after 5 in the East Coast and probably later elsewhere. We will resume the program tomorrow at 7 a.m. California time. So in the morning tomorrow, we have the full day of additional lecture and on the topics and theme in uveitis and ocular inflammatory disease. So everyone take a good rest, have a good dinner, run, do something fun, and we will see everyone tomorrow. Thank you.
I'll look forward to seeing all of you tomorrow.
Thank you very much. Bye-bye, everyone. Thank you.
Thank you both. Have a
Thank
good
you so
evening.
much.
Yes.